Hi class. So today I am going to finish up the lecture that we started earlier. This lecture will get taken down once you guys are done with your final exam so that you have access to it. Up until then, I'm going to skip past the first few slides where we had already had lecture on them and just get to the part where we left off this morning. Some of these slides do not transfer over into Keynote very well, and so you have better copies of them in your lecture because you have the original PowerPoints. All right, so we left off with the picture with the club foot of adults, and we don't see that much here in the US or in developed nations, but we do see it in underdeveloped nations. The next thing we are going to talk about is skeletal limb deficiency. It's also known as congenital limb or reduction malformations, and there's a wide range of severity with these. And most of them are primary defects of development, meaning that as the embryo is developing, the limb just doesn't develop normally. But there is a form of skeletal limb deficiency that is related to constriction with an amniotic band. And so what happens with amniotic band syndrome is that the amnion, which is part of the placenta, becomes disconnected. So we have multiple layers. This is the inner layer of the placenta that's right up against the baby. So that amnion becomes disconnected from the rest of the placenta and it just sort of hangs there. Well, the baby is moving around and everything, and it puts its hand into this amnion that's hanging there like a curtain, and it gets stuck in it. So you can see in this picture how it sort of wraps around the fingers. If it happens early enough in the pregnancy, it can cause there to not be any blood flow in that area, and as a result, the area becomes necrotic and it falls off and usually gets absorbed in the amniotic fluid and you see no sign of it when the baby's born. Well, these amniotic bands can exist anywhere. They can be around the head, they can be around a leg, they can be around fingers, they can be around toes, they can be around an entire leg. So it's not especially uncommon for us to see babies born that have had amniotic band syndrome. The bottom picture on this slide is a picture after a baby was born. I think that that is a knee that they have their thumb on, and you can see this amniotic band just below the knee, and you can see how it can cut off the circulation. So basically what happens, just like anything else where if we have constriction on something for a long period of time, there'll be muscle atrophy and like an indentation where that is. Take a look at somebody's wedding band finger sometime, and you'll see that that area actually is smaller than the opposite hand where the person doesn't wear their wedding band. So same idea here. And you can see how that band has made a little groove in that arm. And in this particular case, it hasn't resulted in the loss of the limb, but it can result in a loss of a limb. Other types of limb deformities, amelia is an absence of an entire extremity. Myromelia is a partial absence of an extremity. Phocomelia is the deficiency of the long bones with relatively good development of the hands and feet attached at or near the shoulder or hip. So that's what happened with the medication that was given in the 1950s to prevent abortion or spontaneous abortion, and or miscarriage is the other word that we use for that. And so it caused these limb deformities that's known as phocomelia. And then we talked about how prenatal amniotic band syndrome can affect this as well. This guy is quite famous. He's Australian, if I remember right, or New Zealand. A New Zealander, I can't remember exactly which one. And he's a speaker that talks about how life could be really bad, but he's chosen to have a positive attitude. And so it's kind of if I can live my life with a positive attitude and I have no arms or legs, you ought to be able to live your life with a better attitude. So you notice with him, he has no arms. He does have a little something at his legs where it's like a phocomelia with the leg, but in general, he has no arms or legs. The therapeutic management of limb deficiency is they get them into prosthetics as early as possible. The early prosthetics encourage maximum exploration and development during infancy. And with phocomelia, digits may be surgically modified and preserved and reattached for use with the prosthetics. Osteogenesis imperfecta actually means bone that is imperfectly made from the beginning of life, which is kind of an interesting, if you look at the word osteo is bone, genesis is the making of it, but it's made imperfectly, imperfecta, and we call it OI. And it's a group of heterogeneous inherited disorders of connective tissue. It's characterized by excessive fragility and bone defects, and there's defective periosteal bone formation and reduced cortical thickness of the bones. There's also hyperextensibility of the ligaments, which causes some of the damage that happens with these children. I want you to not focus on all of the different varieties of OI. I would rather have you think about more of the major symptoms and side effects that we see. So the signs and symptoms of OI is that it ranges from lethal forms to mild forms with very few visible symptoms. Often there's muscle weakness, fragile skin, bleeding, easy bruising, frequent nosebleeds. There's hearing loss because if you think about it, you have bones in your ears that you hear with. So if your bones are not developing normally, then the bones in your ears are not developing normally either. They get fatigued very easily because of the muscle weakness. There's joint laxity, means it moves easily. Often there's curved bones. Again, it has to do with the fact that the bones are not developing and hardening with the calcification the way they should. Scoliosis is common with it. One of the things that they look for when they're diagnosing it is whether or not the sclera is blue, and I have some pictures of that on the next slide. And then they often get something known as dentogenesis imperfecta, which basically means their teeth are not forming correctly either. They're often very short stature because of their rib size and the fact that they have frequent broken bones. They often will have a restrictive type of pulmonary disease and breathing difficulties. I took care of a baby when I was living in Canada, and that baby's mother had osteogenesis imperfecta. She was told that she should not have become pregnant because she had such a restrictive pulmonary disease going on because there wasn't much room for her ribs to expand. So then with a pregnancy, it would put even more pressure on the diaphragm and she wouldn't be able to breathe well. The day that they delivered her at 24 weeks, she had a CO2 up in the 80s and was quite ill, and after delivery went to the intensive care unit. So here's a picture of a lady who has osteogenesis imperfecta, not the one that I was just talking about, and she has her little baby with it. With it being inherited, they usually are not advised to become pregnant and to have children, but definitely that does happen. And you can see the structural deformity that she has in her hand, and that happens from her having frequent breaks in the wrist area and in her hands. The next picture over shows the blue sclera, and so instead of having a white sclera, you can see that it actually has a blue tone to it, and that has to do with totally forgotten what they say that what causes it, but basically it again has to do with that formation of the ligaments and bones that aren't normal, which I know that sounds kind of weird with the eye being involved, but I'll try to look that up and let you guys know about that. The picture that's right next to it is of a baby right after birth. And these kids are so fragile that even before they're born, they start getting broken bones. And you can see on this picture some of the broken bones, some of the healing sites. So they have a lot of breaks with various stages of healing. So now think about the fact that when kids come in and there's a suspicion of abuse, one of the things that we do is to do full body x-rays of them, and we will often see breaks at various stages of healing on these kids that have been abused. So as you can imagine, it's very difficult with these children because if for some reason they go into a hospital that doesn't know them, then there is the suspicion that this family is abusing their child. And it's been something that the OI community is quite aware of and work to battle against it. So often families will actually carry around with them medical papers to show that they're not abusers, or and the children often will wear medical alert bands that say that they have osteogenesis imperfecta, so that they don't get taken away from their families for abuse when no abuse is happening. Just one of those little side pieces that we have to think about with these children. So the therapeutic management of OI, the goal of therapy is to minimize fractures, to maximize their mobility, and to maximize independent function. Rehabilitation is directed towards preventing contractures and deformities and muscle weakness and osteoporosis. So if you think about it, the reason they have scoliosis is because of the osteoporosis that they have, or the weakness of their bones. Also, they try to limit the amount of malalignment in the lower extremity joints so that as much as possible they're able to ambulate. Drugs are of limited benefit, but pain management is something that's very important for these kids because they constantly have broken bones. And of course, the problem that goes along with that is constipation. And there are some experimental medications being used, like biphosphonates, same as the drugs that we give to women with osteoporosis. Growth hormone, and increased vitamin D intake to see if that will help to make the bones a little stronger. If multiple fractures occur, then they need to rule out OI. The prognosis with the life expectancy, um, it's not affected in persons with mild to moderate symptoms. So in other words, they're going to live as long as anybody else does. With more severe symptoms, it does shorten their life, and in some cases, there's death at birth or infancy or even fetal deaths with the more severe forms. Respiratory failure is the most frequent cause of death, followed by accidental trauma. Because if you think about it, accidental trauma is a high reason for death in general for children, but then you add to it these children that have brittle bones, and so then that increases their risk factors. As far as nursing management is concerned, we're going to handle these kids very carefully. We don't, a lot of people, when they change diapers on babies, they pick up the legs with the ankles and kind of hang the kid by their ankles up in the air while they put the diaper underneath. Well, this is not a kid that you want to do that with, because just doing that can cause them to get a broken bone. So when we go to change diapers, when we do position changes with these babies, we're going to make sure that we have good support under the buttocks, in the shoulders, and we're not going to do anything that might cause pulling of the extremities. We have to be really careful when we start IVs on these kids, because we often will start IVs by taking their little hands and holding them really tight and then starting the IV. Well, with our hands being the tourniquet. And when we do that, we have the potential of breaking their bones. So we have to be very, very careful with how we handle these kids. We want to make sure that the parents and the child themselves are educated. Right now, Shriners is running a commercial with this one little boy that he has osteogenesis imperfecta. He's just the cutest guy I've ever laid eyes on when he's talking about his osteogenesis imperfecta. And basically he understands his disease. He understands that his bones break easily, and he's been in and out of the hospital most of his life because of these constant breaks in his bones. He's getting therapy at Shriners so that he's learning how to ride a bicycle and even how to bear weight on his legs. Definitely, it's a multidisciplinary team evaluation. And when kids come in for no particular reason, having broken bones, then this multidisciplinary team needs to evaluate this child to make sure that it's an OI situation versus an abuse situation. And we've already talked a little bit about that. If they're receiving pamidronate, which is Boniva, we need to monitor their temperature. We want to monitor for musculoskeletal pain. Here is a medication that's supposed to help to make the bones stronger, but it can actually cause musculoskeletal pain as well. We need to watch for CNS symptoms and alteration in renal function. And specifically, one of the side effects that's associated with it is osteonecrosis of the jaw. So if they start complaining of pain in their jaw, the medication is stopped. Some of the nursing considerations include family education and occupational planning and genetic counseling, because this is something that's passed on from generation to generation. The mother that whose child I took care of in the NICU in Canada, her brother had osteogenesis imperfecta, and there were other relatives within the family, aunts and uncles, that also had OI. And just for general information, that little baby that was born at 24 weeks passed away in less than 24 hours. leg, clave, Perth's disease. It's a self-limiting idiopathic disorder that occurs in children ages 3 to 12 years of age. It's more common in males, especially between the age of 4 and 8 years old. And basically what happens is they have avascular necrosis of the femoral head. So in other words, the femoral head does not have blood flow to it, and so it's not getting oxygen to it, and in 10 to 15% of cases, there's bilateral hip involvement with it. Most have delayed bone age, so in other words, the bones do not appear as old as the child actually is. The pathophysiology, they don't know what causes it, but it involves a disturbed circulation to the femoral head with ischemic aseptic necrosis. After resolving, they may have normal femoral head or may have severe alterations, depending on how soon they catch it and diagnose it. It really comes on very insidiously. They may have a history of a limp or soreness or stiffness or a limited range of motion. There may be a vague history of some kind of trauma, like they might say, oh, I fell down or something like that, but it's as though the pain in the limp is worse than what the injury should have caused. They tend to be more evident when they first get up in the morning, and also if they've been involved in a lot of activity. It's diagnosed by x-ray, and the treatment goal is to keep the head of the femur in the acetabulum, similar to what we do with DDH. So what they do is they put them in various appliances and devices to keep that position with the head of the femur in the socket of the hip, and which is what the acetabulum is. And so if you think back to the DDH patient, that as they got older, they went into a spica cast, they do the same things with these kids. Or there's actually like a brace that they wear where there's a bar in between the legs that keep the legs apart. And so basically the treatment is rest with no weight bearing initially. In some cases they may do surgery. And they do this home traction with the spica cast or the device that keeps the legs spread at home. Often what they'll do is do this treatment over the summer. And so these kids are not going out and playing and everything, but in order to keep them so that they're not missing too much school, they'll do their treatment over the summer. The prognosis is that it is self-limiting. The outcome depends on early and efficient treatment and the age of the child at the onset of the disorder. As far as our nursing care management, we want to identify affected children and get them referred to orthopedic surgeons. We want to make sure that we do teaching with the parents and the child as far as what's going on, why they need to have the treatment that they're having, how long in general that treatment may last, and what needs to be done with it. And also, you have to consider that these are kids that are very active. They went from being very, very active to all of a sudden now they have to rest. And so compliance is a very big deal. And again, they tend to do the treatment in the summertime when the kids aren't in school. Well, that's when the families normally go on vacation. So then it's like, well, it won't hurt if he comes out of his brace for a couple hours while we're at the beach, will it? Well, yeah, it does make a difference because that head of the femur can slip out of the socket. So, compliance is a really big thing, and teaching is the way that we help them to become compliant. I'm not going to spend a lot of time talking about defects of the spinal column because that's you did your spinal screening course just the other day. So we know about the different types. Kyphosis is an abnormally increased convex angulation in the curvature of the thoracic spine. So remember where these things are, whether it's in the thoracic spine or the cervical spine or the lumbar spine. That's something that's you should think about with these. It's the most common form of kyphosis is postural, back to that whole thing, stand up straight. And it can occur secondary to tuberculosis, arthritis, osteodystrophy, or a compression fracture of the thoracic spine. Lordosis is accentuation of the cervical or lumbar curvature beyond physiologic limits. It may be idiopathic or secondary complication of trauma. And it can occur with flexion contractures of the hip and congenital dislocated hip. So remember we talked about with the DDH that these kids, if they're not corrected or somebody misses it, we may see lordosis with them. In obese children, the abdominal fat alters the center of gravity, and that causes lordosis. So if you think it's the same kind of action that happens with pregnancy. And in fact, lordosis can be one of the side effects of teen pregnancies because they're in that growing stage and the spine isn't meant to be in that position because of the altered center of gravity. Scoliosis is the most common spinal deformity. It's a complex spinal deformity in 3 different planes with a lateral curvature, spinal rotation that causes the rib asymmetry, and thoracic hypokyphosis. It can be congenital or it can develop during childhood. And you all know a little more about that after having sat in class the other day. There's multiple potential causes, but most of the cases are idiopathic, and you can remember idiopathic means we don't know what causes it. It generally becomes noticeable after the pre-adolescent growth spurt. Really pay attention to this because I'm seeing questions about when does it happen, and they want you to think adolescence. And so make sure that you really pay attention to these questions about when do these things happen. You may have complaints of ill-fitting clothes because of that curvature that's happening with it. Finally, the American Academy of Pediatrics and the American Association of Osteopathic Surgeons finally decided that they can agree on how to treat scoliosis. Up until a couple years ago, one group said screen at one time, another group said screen at another time, and so it made it really confusing. So it's really nice that they finally decided to agree. And so as you know from going to class, that we want to screen girls at age 10 and 12 here in Texas, and boys at age 13 to 14, which corresponds with grades 5 and 7 for girls and grade 8 for boys. So most school nurses are choosing to do the screenings at those grade levels rather than age levels. And for those of you that have already gone to the hearing and vision screening, if you think about it, we're also doing hearing and vision screenings at the same time. So it makes sense that we do all 3 screenings on the 5th and 7th grade girls. And then, of course, then we have to pull the 8th grade boys in for their screenings for scoliosis. The diagnostic evaluation includes the standing radiographs to determine the degree of curvature, the Adams forward bend test, which is what we did in the screening courses, and we're looking, the Reiser scale looks at the degree of angle in the spine. We definitely are looking for asymmetry of shoulder height, scapular or flank shape, or hip height. There's often a primary curve and a compensatory curve so that the head is aligned with the gluteal cleft. So we all know what the Adams forward bend test is after having gone to class. I'm not going to spend time there. Basically, the therapeutic management is a team approach. Usually we try to do bracing, and we follow these kids very closely. The bracing will not correct what's already there, but it will prevent it from getting worse. And so what we're looking for is whether or not these curves continue to get worse as far as whether or not we're going to do surgery. There may be some exercises associated with it, and ultimately there may be surgical intervention for severe curvatures, which includes instrumentation and fusion. So if you look at this slide, this is what the braces look like. So if you can imagine being in these braces for 23 hours a day. Often the doctors will let them out of their braces if they have other activities or something that they're involved in, because we still want these kids to be active kids. So if somebody runs track or they play basketball or something like that, what they'll tell them to do is, look, if you wear your brace all the other times except when you're playing your sport, that's good enough, because you will still be in the brace more hours than you're out of it. So that's often something that they look at. I wanted to show this one picture because this is a before and after. It's also a picture of a poorly done x-ray. So the picture on the right is obviously before they did surgery. You can see the underwire for this person's bra. Usually when radiologists see an x-ray that looks like this, they will make you as the nurse redo them. And so I'm really kind of surprised that they let this one go by. And you can see her earrings hanging and stuff like that. So it's kind of an interesting x-ray to me because of how picky radiologists will get. But it's pretty obvious what's going on with this girl's spine. And then the picture on the right is after they've done her surgery, and you can see how much straighter her spine is. What's interesting is to look at how the cervical spine is still curved, even after they did the work on the thoracic spine. Some of the nursing care management is concerned with body image because, again, my body's not normal. I've got a curve in my spine. I have to wear a brace. And so obviously this is something that causes a lot of non-compliance, and it's also something that makes them feel very self-conscious. There's concerns about social isolation. Nobody's going to like me because I have to wear this brace. Concern for prolonged treatment of their condition because this isn't something that just goes away in a short period of time. They're in that brace for a long period of time. And then there can be family issues. When we look at pre-op care, it's going to involve having x-rays and labs done. They're going to be doing pulmonary function testing because this curvature of the spine can change how the lungs can expand because it affects the position of the ribs. they lose a lot of blood in these surgeries. And so sometimes what they'll do is donate their own blood prior to their surgery so that they're not having to get as much blood from other sources. In other times, they do blood salvage treatments where they're able to recycle the blood that they're losing and give it back to them. I will say that I noticed as I was doing research for this last year that there's a new surgery for this where it's being done in a minimally invasive way, and there's not as much blood loss in that way. I mean, basically, they used to cut these kids from stem to stern down their back and basically fillet out their back muscles to do all of this surgery. But now there is a minimally invasive procedure involved, and it's really kind of cool to see the video. And I'm sorry I didn't add that one in on this. Emotional support is going to be very important because it's kind of scary, the idea that they're going to do surgery on your back and open up your back. Post-operatively, vital signs are going to be monitored very closely. We're going to be looking at wound and circulatory systems assessments very closely initially. Pain control is going to be a very big deal for these kids because they're not going to get up and move if they hurt. Because of their surgery, we don't want them to bend. So we're going to log roll them whenever they have to be moved. So the whole body moves, just like a log. Skin care is going to be very important. We've got to turn them from side to side to side. In some cases, initially, they're actually put on a bed that sort of sandwiches them in between. And then you're able to turn the whole bed. And then the bed opens up again so that they can look around and see things. And then when it comes time, then that piece of the bed goes back over and they get sandwiched and turned the opposite direction. Assessment of neurostatus of the extremities is extremely important with these kids to make sure that there hasn't been any damage to the spine. And we try to get these kids up and walking as soon as possible because that's going to help them heal faster. Osteomyelitis is an inflammation and it's an infection of bony tissue. It can be caused by exogenous or hematogenous sources. And the signs and symptoms begin abruptly, and they resemble the symptoms of arthritis or leukemia. There's marked leukocytosis, and bone cultures are obtained from biopsy or aspirate to rule out leukemia versus osteomyelitis. The early x-rays may appear normal, but the bone scans are definitive for diagnosis. And you can see by this picture where most of the osteomyelitis occurs at the head of the femur and in the knees, in the ankles, and less so with the upper arms and shoulders or the skull and the hips themselves, with the ribs having the least amount of osteomyelitis that happens with them. Exogenous osteomyelitis is when an infectious agent invades the bone following a penetrating wound, an open fracture, or contamination in surgery, or a secondary extension from an abscess or burn. I've seen a few cases where a kid got cellulitis from an IV infiltrate and ended up with osteomyelitis. And they got theirs in the heel when I saw that happen. So it's something that we watch very closely. Hematogenous genus osteomyelitis, there's a pre-existing infection already in the body that spreads to the bone. And the sources can be things like furuncles, skin infections, upper respiratory tract infections, abscessed teeth, or pyelonephritis. Any organism can cause osteomyelitis, and basically what can happen is infective emboli travel to arteries in the bone metaphysis, causing abscess formation and bone destruction. The therapeutic management is that they may have a subacute presentation with a walled-off abscess rather than a spreading infection. And so we want to get prompt, vigorous intravenous antibiotics for an extended period. These kids may be on IV antibiotics for 3 to 4 weeks or up to several months to kill off all of the infection in their bone. We're going to monitor their hematologic, their renal, and hepatic responses to the treatment. Because remember, their hematologic is going to be affected by the fact that the bone is infected. So their bone may not be producing as many red and white cells as we would normally expect. And if they're having renal problems from their antibiotics, then they're not going to produce red cells or white cells either. And so that can be a problem. As far as nursing care, these kids are on complete bed rest with immobility of their limb. Pain management is a major concern, and so we want to make sure that we meet those pain management concerns. Long-term IV access for antibiotic administration is going to result with them either having a PICC line or some other centrally placed line to receive their antibiotics. Nutritional considerations, considering that they're not moving and they're on bed rest, and all of those things that go along with immobility is going to be a major factor for them. They're going to be on long-term hospitalization and therapy. Even as they get better, they may send them home on home IV therapy, but then they'll have a home health nurse that comes out and gives them their antibiotics. In some cases, they may train the family to do it, but in general, they usually want to watch them a little bit closer. And of course, there's psychosocial needs that are being affected by them having to be on complete bed rest. So they're not able to go outside and play with their friends or do things with their families like they're used to doing. Somewhat related, but not completely, is septic arthritis. And it's also known as superlative pyrogenic or purulent arthritis. And the causative organisms may vary with the age of the child. It may result in extension from soft tissue infections, and it may involve any joint, but it's most common in the hip, the knee, or the shoulder. It usually only involves one joint, so it doesn't tend to be bilateral. Characteristic appearance, the joint is warm, tender, painful, and swollen, and it frequently follows a traumatic injury. They have fever, leukocytosis, and increased sedimentation rates. Gonorrhea is one of the most frequent causes of septic arthritis in sexually active teenagers. Diagnosis is made from blood culture, joint fluid aspirate, and x-rays. And the treatment goals are to prevent destruction of the joint cartilage, decompress the joint to main circulation to the epiphysis, eradicate the infection, and prevent secondary bone infection and hematogenous spread. So basically, we're trying to prevent osteomyelitis as well. Kind of going along with these joint infections is that tuberculosis can affect any part of the body. We always think of TB as being pulmonary TB, and that's where we start out with it. But hematogenous dissemination of pulmonary TB can result in a TB infection of the bones or the joints. The common sites of skeletal TB are the fingers and toes, or the spine, or a spinal erosion, and we call that pot disease. The clinical manifestations may be difficult to assess. Usually there's pain over the affected areas with motion, postural changes, a limp, and or localized swelling. The diagnosis should be considered in a child who's had exposure to TB and has a positive PPD, and then all of the joint pain. The therapeutic management is surgical debridement of the joint, oral antituberculin therapy for a year. The prognosis is excellent with treatment, and then we're going to carefully monitor the disease contacts. In other words, where did this kid get his disease to start out with, and make sure that they're getting treatment as well. We're going to talk a little bit about bone tumors. Osteosarcoma and Ewing's sarcoma account for 85% of primary malignant bone tumors in children. So in other words, these are tumors that started in the bone, and now, secondary tumors in the bone are when they've had a cancer somewhere else that has spread or metastasized to the bone. Primary bone tumors occur more commonly in boys, with the highest incidence during the accelerated growth period of adolescence and pre-adolescence. The diagnosis of bone tumors, we're going to rule out trauma or infection first because pain is associated with it. And a definitive diagnosis is based on radiologic studies, CT scans, and bone biopsies. MRIs can be used to evaluate neurovascular and soft tissue extension, and lab studies show elevated alkaline phosphatase with some of the bone tumors. Osteosarcoma is the most frequent malignant bone tumor in children. The peak incidence is ages 10 to 25, more in males than females, but obviously girls can get it as well. Most primary tumor sites are in the metaphysis of the long bones, and especially the legs. It occurs more than 50% occur in the distal femur, so not up by the hip, but down by the knee. Other sites are the humerus, the tibia, the pelvis, and the jaw. The therapeutic management of osteosarcoma, the traditional approach is radical surgery resection and amputation of the affected area, but they're starting to do more limb salvage procedures involving resection of the bone with prosthetic replacement of the affected area. So in other words, they're putting a prosthetic bone in when they take out the affected bone. Chemotherapy is usually how they treat it, accompanying that surgical treatment. As far as the nursing care and management of osteosarcoma, preoperative preparation is crucial, because these kids don't have, it's like 1 minute they're these healthy, active kids, and the next thing they turn around, they don't have a leg. And so they need a lot of support during the adjustment period to the concept of amputation or surgical resection of their leg. Body image is obviously a major thing. Who's going to love me now that I don't have a leg? Because remember, part of becoming a teenager is falling in love and having your first boyfriend or girlfriend. Pain management is something that they're going to be very concerned about. And so with that concern, we're going to want to make sure that they understand that they are going to have good pain control, and we're going to help them have that. We need to, before surgery, talk to them about phantom limb pain. They won't really completely understand it until they experience it, but when they expect it, it's less frightening than if they don't know that that's something that could happen. Remember that we treat phantom limb pain with amitriptyline and it's been shown to be fairly effective in controlling phantom limb pain. Ewing sarcoma is the second most common malignant bone tumor in children and adolescents. It's rare in those children that are older than 30 or people that are older than 30 years of age. It usually arises in the marrow of the bone, especially in the femur, the tibia, the ulna, and the humerus. It can also arise in the vertebrae, the pelvis, the scapula, the ribs, and the skull. Both types of sarcomas, the Ewing's and the osteosarcoma, if it metastasizes, it tends to go to the lungs. If it doesn't go to the lungs, it goes to another bone or the bone marrow. The treatment of Ewing sarcoma is a radiation rather than osteosarcoma where we go in and do an amputation. Chemotherapy is usually used as an adjunct to the radiation. Surgical resection is necessary in some cases, and it's usually possible to preserve the affected limb in those cases. Prognosis is best if there's no metastasis at the time that they are diagnosed, and the further out the lesions are, the more distal they are, the better possibility of a cure. As far as the nursing management, prior to treatment, we want to discourage active play or weight bearing on the affected limb because the cancer makes it weak, and so they can have fractures. Throughout treatment, we're going to deal with the adverse effects of chemo and radiation and help the kids to deal with that. We're going to give kids honest and direct answers to their questions. These kids are old enough to understand what's happening to them. And so it's important that we talk to them honestly. We're going to offer various forms of therapy to help the child and the family deal with the psychological effects of their diagnosis. And obviously, nutritional concerns are present throughout the treatment because if you think about it, this is a time of rapid growth, but you're giving them chemotherapy or irradiation, that tends to make kids not hungry or have an upset stomach, so they're not wanting to eat. So it's really important that they're given high protein, but good nutrition. And so often we have like special milkshakes and things like that that have additional protein added to them because they're usually able to keep those down. Often they'll have these milkshakes sitting at the bedside so they can take little sips of them from time to time if they're having an upset stomach. And we're also going to give them medications to control emesis and pain. Rhabdomyosarcoma is a malignant neoplasm that originates from the undifferentiated mesenchymal cells in the muscle, the tendon, the bursa, the fascia, or in fibrous connective lymphatic or vascular tissue. The name reflects the tissue of origin. Myosarcoma means myo is muscle, and rhabdomyosarcoma means, rhabdo means striated muscle, so striated muscle sarcoma. And the potential sites for that is the orbit, the nasopharynx, the paranasal sinuses, the middle ear, the retroperitoneal area, and the perineum. Diagnostically, we look for signs and symptoms that depend on the site of the tumor with compression of the adjacent tissue. So you're going to have pain. The tumor in the orbit is symptomatic early in the course of the disease, and so they tend to get rapid diagnosis with if it's in the orbit. Tumors that are in the retroperitoneal area has minimal symptoms, and as a result, the tumor has a tendency to grow and get very large. Many of the symptoms are very vague, and they're common to childhood maladies like earaches. And so often it gets ignored until it gets a little more advanced. Some of the tumor treatments and prognoses, they're highly malignant, and there's frequent metastasis associated with them. We try to completely remove the tumor if possible. In some cases, it's not, and so they use radiation for most of the tumors. Chemotherapy may shrink the tumor prior to radiation, and long-term chemotherapy, usually that's lasting 1 to 2 years, is commonly done. And the prognosis is fairly good depending on if it's metastasized and where it's metastasized to. Juvenile idiopathic arthritis, or JIA, is also known as juvenile rheumatoid arthritis, juvenile chronic arthritis, or idiopathic arthritis of childhood. The cause is unknown, although they believe that there's immune and environmental causes. The peak ages for developing it are between 1 and 3 years old, and then it skips a few years, and 8 and 10 years old children start developing. Often it's undiagnosed. They just know that these kids have growing pains. And so, yes, kids do get arthritis too. So a nurse is reviewing the chart of a child with juvenile idiopathic arthritis. The nurse knows that there's involvement of 5 joints symmetrically. What is the technical name for this type of arthritis? Pauci-articular. Pauci means a lack of. So lack of articular, no, that wouldn't go with 5 joints being involved. Polyarticular means more than 1 joint. Systemic would mean that it's all over the body. And primary. Well, the answer to this is that it's polyarticular. Polyarticular juvenile idiopathic arthritis involves 5 or more joints and often affects the body symmetrically. Pauci-articular involves 4 or fewer joints, and it's quite often the knee. Systemic involves fever and rash in addition to joint involvement, and primary is not a type of juvenile idiopathic arthritis. So like I said, pauci, people will often say there's a paucity of evidence. It usually means there's a lack of evidence. So that's where that word kind of goes in there. So less than 4 joints. JIA is actually a heterogeneous group of diseases. Systemic arthritis and like I said, we talked about this just a minute ago, involves 1 or more joints with at least 2 weeks of fever, rash, lymphadenopathy, hepatosplenomegaly, and serositis. Oligoarthritis is 1 to 4 joints for the first 6 months that's involved. Polyarthritis, rheumatoid factor negative, has 5 or more joints in the first 6 months, and with negative rheumatoid factor. Polyarthritis with rheumatoid factor, so in other words, it's positive, there's 5 or more joints that are affected in the first 6 months with a positive rheumatoid factor. Juvenile arthritis, in 90% of children, rheumatic factor is negative. In some, symptoms may burn out and become inactive. Chronic inflammation of the synovium with joint effusion and destruction of the cartilage and ankylosis of the joints occurs as the disease progresses. So the symptoms that we see are the same kind of symptoms that we would see with other forms of arthritis. Stiffness, usually worse in the morning than in the evening. Swelling, you can see the difference between this child's right knee and their left knee. Loss of mobility in the affected joints. If you've got stiffness and swelling, you're not going to be moving that joint very much. Often, if you touch it, it's warm to the touch, usually without erythema. So it's warm to the touch, but it's not red. Tender to the touch in some cases. Symptoms tend to increase with stressors. So this is very much like these autoimmune diseases, and they really do feel that in many cases that's what's going on with juvenile rheumatoid arthritis or idiopathic arthritis, is that there's an autoimmune factor to it. And because of the effects on the joints, there can be joint delay or growth retardation, which basically means that these kids are going to be shorter. The diagnosis is done, there's no definitive diagnostic tests. However, we do see elevated SED rates in some cases, but not all of them. There may be anti-nuclear antibodies fairly commonly, but not specific for JIA itself. There may be leukocytosis during exacerbations of JIH. But the diagnosis is based on the criteria of the American College of Rheumatology, which says that these symptoms are there. So the diagnostic criteria is that it started before the age of 16. It affects one or more joints. It lasts longer than 6 weeks, and they've been able to exclude other forms of arthritis. So if osteoarthritis was taking place, then you wouldn't be known as a JIA sufferer. The therapeutic management, there's no specific cure. So this is something that's not going to go away, although there's going to be periods of remission and periods of exacerbation. The goals of therapy are to preserve the function and prevent deformities and relieve symptoms. Therapeutic management focuses on the control of inflammation, pain control, and maintenance of mobility. Iridocyclitis and uveitis, which is an inflammation of the iris and ciliary body, are unique to JIA, and it requires treatment by an ophthalmologist. As far as medications that are used, they're started out on NSAIDs, and NSAIDs may work for a while for these kids when they're first diagnosed. If those aren't working, then they may start the slow-acting anti-rheumatic drugs, SAARDs, or corticosteroids. Cytotoxic agents like methotrexate are usually tried before the immunologic modulators like Humira. And so, if you think about the commercials for Humira and some of the other immunologic modulators, they'll say, this is good for people where methotrexate hasn't worked. So if they try methotrexate and it doesn't give them relief, then the next step is to use these immunologic modulators. As far as management is concerned, therapy is individualized to each child. They may receive physical and occupational therapy to keep their joint mobility, and nutrition and exercise are very important. These kids may not feel like exercising, but they need to do it so that they keep their range of motion and they don't develop muscle atrophy and contractures. In some cases, they may use splinting devices to help them deal with pain. Pain management is very big, so they're going to be on those medications that we noted earlier. The prognosis varies depending on the child and how severe their JIH is. And those are some of the nursing considerations. Somewhat related to JIA in that we consider it to be an autoimmune disease is systemic lupus erythematosus, or SLE. It's a chronic multisystem autoimmune disease of the connective tissues and blood vessels. It's characterized by inflammation, and the symptoms are varied and unpredictable. The symptoms range from mild to life-threatening. The incidence of SLE is more common in females ages 10 to 19. It's also more common in African American, Asian, and Hispanic children. There does tend to be a familial tendency, even though we say that it's an autoimmune disease. The cause is unknown, but possible triggers are hormonal imbalances, immune disorders, environmental exposures to drugs, infections, stress, or chemical agents. The clinical manifestations are cutaneous lesions, lymphadenopathies, nausea, vomiting, diarrhea, and pain, generalized weakness, arthritis, joint pain, and stiffness without deformities. Forgetfulness, seizures, and paralysis can happen. Pleurisy and pericarditis is usually how some of these people die from lupus. Proteinuria and renal failure can happen as well. And if you look at this, we often see mouth and nose ulcers. They get this butterfly rash on their face. And lupus is the Latin word for wolf. And so if you really use your imagination, you can see a pattern on the face that's similar to the markings of a wolf, which is how the disease got its name. It becomes a life-threatening disease when we start looking at the development of endocarditis or inflammation of the fibrous sac. Anemia and blood pressure is associated with it, and pleuritis, pneumonitis, pulmonary emboli, and pulmonary hemorrhage are problems that can result in women especially getting it, although men can get it, dying at a very young age, in their 20s. The criteria for diagnosis of SLE is they have to have 4 of the following findings: a renal disorder, a neurologic disorder, hematologic, immunologic, anti-nuclear antibodies, the butterfly rash, discoid rash, photosensitivity, oral ulcers, arthritis, or serositis. The therapeutic management is to control the inflammatory response. So these kids are on NSAIDs, corticosteroids, and anti-malarial drugs, if you remember when we were studying this in pharmacology. And when they have flare-ups, or if they have severe SLE, they may be put on corticosteroids and immunosuppressive drugs as well. As far as nursing management is concerned, we want to prevent and monitor for complications. We want to educate these young women to have a healthy diet, have regular exercise, get adequate sleep and rest. It's really important because stress tends to make exacerbations of the disease. If they're going to be out in the sun, we want to make sure that they have application of sunscreen daily because they are photosensitive, and that they protect themselves against cold and heat. We want to monitor their blood pressure. They should have yearly vision screenings done, and they need to be taught about medication administration for the medications that they're on. And family support is going to be very important. So if you look at this picture here, this is the butterfly rash that we talk about with SLE. So that pretty much sums up everything. If you guys have any questions, send me off an email and I will try to answer them as best I can. But you want to make sure that as you're studying, that you're looking at nursing implications, things that we're watching out for in all of these disease states. So I'll see you on Wednesday, and good luck. Bye.